very good, because you can see that we're taking all of these separate episodes of the separate patient numbers. So, and we're collapsing this all into one worst overall toxicity. So these 29 patients, they may have had, although grade 3 toxicity was their highest, they may have had grade 3 larynx and grade 3 salivary gland and grade 3 skin toxicity, but we only count that once. So it's possible that there are late toxicities or late effects for all three groups that we're not accounting for. So we probably are underestimating late effects. What about survival and salvage laryngectomy? Well, when we looked at salvage laryngectomy within 1 year of randomization, we clearly see a significantly poorer survival in that group of patients compared to those who had no laryngectomy. And I put over here for you the numbers of patients, and you can see that in the induction arm, 30 patients had a laryngectomy year 1, 39 in the radiation, and half that, 19 in the concomitant group, and you see the same type of thing reflected beyond year 1. These are the totals. Again, most of the laryngectomies were in the first 2 years, and when we look at laryngectomies beyond that first year period, we see no significant difference in survival. So clearly, that's signaling those patients that fail early are of a resistant group that we need to identify better earlier on. And for your interest, I put this data up here. You may be wondering, laryngectomy for necrosis or dysfunction, was that different in the groups? And you can see that it wasn't. So for the entire study period, 4 patients in the induction arm, 2 in concomitant, and 3 in radiation underwent laryngectomy for these reasons. And again, we don't see within the concomitant group a worse outcome here to suggest more problems with that group in terms of late effects. So survival and late effects, no significant differences in overall survival, no differences in late effects detected, more deaths unrelated to cancer or treatment in the concomitant group, which are unexplained. Could this be unrecognized late effects of treatment, or is it just a fluke? Early salvage laryngectomy identified a poor prognosis group. Well, where do we go from here? The last couple of slides, I want to just show some data and questions that that hopefully will be discussed more in the panel. So this is data from 3 randomized controlled trials that included both larynx and hypopharynx. EORTC, 450 patients, 77 larynx, 77% larynx, 23% hypopharynx. T2 through 4, N02, total laryngectomy required as an entry criteria. This study looked at induction cisplatin 5-FU, 50% reduction in tumor required to go on to radiation alone, and that was compared with alternating cisplatin 5-FU and radiation, total 60 gray, so lower radiation dose in this arm. The outcomes, larynx preservation, overall survival, progression-free survival, no significant differences. One has to wonder about the impact of the lower radiation treatment, the lower radiation dose in this arm. The GORTEC trial, 213 patients, 46% larynx, 64% hypopharynx. The population was all T3s, selected T4s, total laryngectomy required. This was a randomization between TPF and PF induction chemotherapy. Not only was reduction in tumor size required, but also return of normal cord mobility was required, and 70 gray was given. And in this study, the TPF regimen patients in the TPF arm had significantly higher rates of larynx preservation than those in the PF arm. Overall survival, disease-free survival were not significantly different. And the TAX-324 study, this is data that Dr. Posner has allowed me to use. It's a subset analysis of his data, 123 operable patients, about half larynx, half hypopharynx, any stage 3-4. Patients were randomized to either induction regimen followed by radiation and carboplatin weekly. And the analysis shows significant improvement in laryngectomy-free survival with the TPF group. Overall survival not significant. Progression-free survival better with the TPF group. We don't have data on larynx preservation or local regional control. So my take on this data is that it's very supportive of other data that we have showing that TPF is a better regimen than PF. It still doesn't get at the question, though, about what should we be doing and what and how do we view that data in light of the concomitant chemoradiation, which is the reference regimen. I think there are critical endpoints that we need to have to demonstrate that a new approach is better. Larynx preservation with function, local regional control, overall survival, and we have to do a better job with late effects. The patient population has to be clearly defined. They should be operable. They should be candidates for larynx preservation from a comorbidity medical standpoint, intermediate versus advanced by TN stage, so we need to decide which patients. And I do not think we should be mixing larynx and hypopharynx without adequate statistical power for separate analyses. Although both patients are at risk to lose their larynx, these are biologically different cancers. The prognosis, survival is different. The radiation fields are different, so that the late toxicities, late morbidities are different. For example, in hypopharynx cancer, there's much greater incidence of esophageal strictures, potential for tube dependence. Drug compliance. We're at risk of underdosing the concurrent phase when we start adding in more intensified induction regimens. We have no data to support similar or better efficacy for non-cisplatin-based regimens concurrent with radiation. And I think we have to say that sequential therapy using a less intensive concomitant regimen will not jeopardize local regional control is a hypothesis that has to be tested in a randomized controlled trial compared to concomitant chemoradiation. And that's it. So I thank you for your attention and looking forward to a lively discussion.